Hello, my name is Colonel Richard Malish. I'm the commander of the Carl R. Darnall Army Medical Center here at Fort Hood. And I'm really pleased to be able to present to you today a performance improvement project that we did here that was really aimed at reducing transfers out of our emergency department. And our goal was really to make sure that we took care of as many appropriate patients as we could in our facility. So I'm going to get started here. I'm going to see if I can move my face up to the top here and make it smaller. And we'll go ahead and start the presentation. So again, this is reducing ED transfers for value and readiness. And you can see the purpose there. And these are my disclosures, and I really have no financial disclosures or this was, of course, not a funded project. It was a performance improvement project that we performed in the course of our duties here at Darnall. Here are the learning outcomes, and really I think one of maybe the most important things is to recognize, as we did here at Darnall, that we have systems in which it's actually pretty easy to transfer patients out of our emergency departments, and that we might have providers that are doing so, not knowing the detriment that it brings to their medical centers, their med-acts. So I'd like to spend some time talking about that and why that happens, and a lot of that is just theory, but I like to go into it. And then I'd like to talk about, as the second learning outcome, how leadership in this realm can really make a difference. And leadership starts with really understanding the problem and visualizing what's happening. And then once you sort of have visualization of the issue, then you can start to manage it or adapt it. And I think that's key, and I think that will be a key point. And then the third learning outcome, of course, is to talk about enablers and how the nurse case managing team can really help you with this project or projects like this. Here's the agenda. I'm going to begin just by quickly describing the Central Texas market, which includes Darnall and then all of our primary care clinics and soldier-centered medical homes. I'm really going to talk a little bit about the problem, spend a good amount of time talking about the problem. It was one that identified as soon as I got here to Fort Hood, but it doesn't, the extent of this problem goes well beyond Fort Hood, and I've actually seen it in almost every medical hospital. Of course, I guess all hospitals are medical, but I've seen it in almost every place I've been in the Army, except for those very large tertiary referral centers like the Walter Reeds, BAMCs, et cetera. But most hospitals in the MHS, I think, can be affected by this problem. So I'd like to go into it for quite a bit. And by the way, I've had conversations with Navy and Air Force colleagues, and the problem of leakage of our patients to the civilian network right through our ERs is actually one that is not just isolated to the Army, that occurs in the Air Force and Navy as well. And then I'm just going to sort of take a walk down a theoretical lane and see if we can try to understand not just the proximal cause, but the root causes of why we would transfer so much work out of our ERs. Next, I'm going to talk about what we did at Darnall to get after it, to improve our process, and to improve our metrics, and really at the end of the day, to improve our hospital and the skill sets of our nursing staff, our provider staff, our ancillary staff, and everybody along the way. So this project is one that's important to me because I think it has layers of impacts. And that's why I took the time to put it together for you here today. Then we'll talk about results and discussion and the way forward. That's the agenda. Let's see if I can figure this out. And here's a description of the Central Texas market. And I always like to describe our medical center as really an enterprise. We have primary care, and of course, that's where the vast majority of our patients are seen. And if all works well, we'll take care of all of their needs without them ever having to come in. And at Darnall, or at Fort Hood, this is really dispersed. We've got 9 primary care clinics. And again, if everything works out well for patients, they'll never need to come to the hospital. They'll get all of their primary care at these 9 dispersed centers. And I just like to say that's where referrals are made. If you do get a referral for specialty care, you will then come to Darnall. And that's where referrals are seen. So we have primary care and then tertiary care. I have stars here, and that's just to indicate that we have some capability. We have 8 ORs. We used to have 6 ICU beds, and that was the census capacity when I got here. We've now increased that to 8, and we'll talk about that. That's the outcome of this performance improvement project. We have 32 medical and surgical beds, and then we have a good variety of specialty services. One thing that I'm not going to talk about, but is important to our mission here, is that we're very heavy in labor and delivery and births, birthing, and pediatrics and things like that. And I'm not going to really talk about our readiness generators, but these are not very different from any of the other medical centers that are out there. So we have just a dispersed primary care network, and then we have the tertiary care center, which this slide is supposed to depict that it's a well resourced and highly capable center. This is just a little bit about our priorities at the Central Texas market. We consider ourselves innovative, adaptive, and agile. We've got a great staff. We've got amazing deputies, very talented skill sets. We consider ourselves innovators in primary care, and I'll be speaking at about the Quick Clinic in a different presentation here today. We strive and we obsess about quality and safety. We've got a great quality and safety team. We consider ourselves a leader in that area. And then really what we do here at Fort Hood, we're on one of the largest installations in the Army with several large FORSCOM units to include 3 Corps, 1st Cavalry Division, several separate brigades. We've got about 38,000 soldiers, and we make sure that force is medically ready. But we also generate a ready medical force. We've got a primary care, a family medicine residency. We've got a ER residency, and then we have a new startup, which is a psychiatry residency. And not only do we take care of our population here, but those residencies create manpower for the entire Army. And as they graduate here, we really generate or we refurbish or we repopulate the ranks, the AMED across the Army. And when we talk about DHA reform, CRDAMC and Fort Hood, we're not concerned about any sort of personnel cuts or anything like that, because everything that we generate has direct importance to Army medicine. And by that I mean primary care, the psychiatry residency, and of course 62 alphas, which are emergency medicine docs. So I'm just going to start with the vignette, and I took command here in early July, really late. It was the last day in June of 2019, and as all commanders, I sat in morning report, and I started getting reports like this, and you can see the date on this, and this is 23 July 2019. But there's 9 transfers out of our emergency department, and as I was going through them, and I'll just in terms of my my credentials, I'm an internist and also a cardiologist. But I looked at these and I just had to ask the question, why? Why are these being transferred? And of course, it wasn't provided to me on the transfer list, but you can see that I have 3 different color stars there. If you see it like a maroon sort of AMED color, my question is, why can't we handle that? That's a very common internal medicine issue or a neurology issue. A hospital such as ours is built to be able to handle those. And so those are the maroon color. In light blue, we did not have a hematologist at the time. But then my question was, why would we transfer that to a civilian hospital? Why wouldn't we just call somebody in the military health system, a specialist elsewhere that could help us manage those types of patients? And what I ended up saying to the staff here is that a knowledge gap is not the same thing as a capability gap. A capability gap, and I'm a cardiologist, so I'll use this as an example. A capability gap would be us not having a cardiac catheterization lab. If we have patients that are having acute ST elevation MIs, we do not have the appropriate capability to manage those. But knowledge is not a capability. If it's a specialty set of knowledge that we don't have on site, then we should pursue that through off-site consultation. And so we stopped accepting, that this is a specialty service that we don't have as a appropriate reason for transfer. And we'll talk about how we got after that. And then in many of these cases, even though we had, and we knew we had the appropriate capabilities, we still transferred these patients anyway. So this is just a random day back in July of 2019. But the question is, what is happening and why is our system allowing these patients who trust us for their healthcare to come into our emergency department only to be evaluated and then have to get into an ambulance and be transferred elsewhere? Here's something that I think is a concern. I asked the staff to look at all of the transfers that had happened that month. This was July of 2019, again, my first month in command. And this is the types of problems that were being transferred. And you can see here in the light blue that the majority was cardiology. So echo, which we have that capability, cath, which we don't. So that would have been an appropriate transfer. So the majority of what we were transferring out were cardiology patients, which works well for me because I'm a cardiologist. And then we had neurology, and as you go around sort of clockwise, you'll see neurology was the next and pediatrics was the next. These were the specialties or the specialty services that we did not have at CRIDEMC, and these provided the justifications for transferring those to the civilian hospitals around us. And again, there was 108 transfers in that month of July. Here's something that's very concerning. And again, this is just a retrospective review of a uncontrolled process that was happening as I arrived to take command of CRIDEMC. Here on the left, you'll see the length of stay that these 108 patients stayed within the accepting facility. If you look in the light blue, 30% of these patients were discharged from the emergency department. So our justification for transfer was that they were too complex or required some type of capability that we didn't have here at Darnall. And when they were transferred to another emergency room for admission and access to all these capabilities that we didn't have, they weren't even admitted. So that's a concern. And that's essentially 1 in 3. And then if you look down there a little bit lower, there were another 17% who were basically kept overnight only to be discharged in the next day. Now, we started our performance improvement project and we said, let's look at all the capabilities that CRIDEMC has and let's compare that to their justification for transfer. In other words, if I'm an MOD and I'm getting ready to transfer a patient, I need to write down this is the capability that's lacking. Now, what I asked the staff to do was take that list of justifications and compare it to the capabilities that were actually used at other hospitals. And again, this should be somewhat surprising to people, but 78% of those transfers, the care that they went on to get at those outlying hospitals, 78% of the time, we had the capability right here at Darnall. So it's interesting, very interesting, and I'll talk a little bit more about why I think this was happening as we move forward. I went back and I said, okay, well, that wasn't a good month, but let's look back at transfers in the 6 months prior to July. And here you can see just the volume of transfers dating back from January of 2019 all the way to July. And the average, I think, is above 108, but 108 certainly wasn't an outlier. It wasn't a bad month, in other words. We typically transferred quite a number of patients out of our emergency department. So as part of the performance improvement project, of course, we wanted to understand why this process was happening. And it's not a behavior that's isolated to CRIDEMC. I'll just begin by saying that. It happens. It happened at hospitals in which I was the deputy or in hospitals in which I work as a clinician. And I've seen it happen virtually all my career. So what are the causes? And I'll just go one by one down the left side. Policy is not typically well known, if it even exists, having to do with what patients are kept and what patients are transferred. Providers, at least here, were concerned that if they kept somebody that was moderately ill or ill, a sick patient, which is what a hospital is here to do, and something went wrong, that they would have to face a risk management committee or be scrutinized for their care. And so they had become so risk averse that the idea of a code blue or something like that happening on in Darnall was considered to be a bad outcome, which is unfortunate. It's just a fact of life that when you're sick, sometimes bad things happen, but it's not a reason to transfer everything to somebody else for them to deal with those issues. There was a safety concern and some sort of, and this doesn't apply to any one person, but it's something that started developing in my mind as I talked to these young docs and young nurses. There was a belief, and I think this is a self-identity thing, that somebody else is going to do something better than what we could do for them here, which surprises me because I've both worked on the civilian side and the military side. And the amount of thought and dedication and vigilance that we put into care in the Army by far outstrips anything that can happen in the civilian world. If you look at what happens in ICUs in the Army versus what happens on the civilian side, you can see that the amount of thought, vigilance, attention to detail in the Army is just simply unparalleled. And so many of these people haven't worked in the civilian side, and they didn't know, and their thought was, well, if they're not here with us, then there's somewhere that's safer. But that's not necessarily the truth. And then there was just, and I'll just go down to number 4 there on the left. It was actually easier to transfer patients than to get them upstairs. And there's reasons for that, and we'll talk about that. And then at the end of the day, there was no oversight, and so which is what we did. But previous to that, there was really no consequences to transferring somebody on. So if you look at those 5 reasons, there's a lot of good thought there, but we'll also see how these things are really sort of driven by something that's a little bit deeper. So those are the proximate causes. And again, this is theory or hypotheses. And what's next is a hypothesis as well, but one that I think if it were ever studied, we would find it to be true. At the end of the day, what is the root cause for a liberal transfer policy? And it is that we're a socialized system. And that means there's no added incentive to give ourselves extra work. Now, the civilian side, and we'll talk about this in the next slide, every additional patient that you bring into the hospital, you can bill their insurance company and make more revenue and more profit from it. And so civilians are incentivized to take on as many patients as possible because that's their source of the revenue. Our system is not, we're salary based. And so the more patients we take on, the more painful and uncomfortable it is for us, the more risk we assume. And there is basically no tangible, and I'm going to be careful here because there is a reward, but we just don't see it in the near future. There's no short-term reward, we'll put it that way. That's one of the problems. And you can see here that I have a vicious cycle. One of the problems is because we're socialized and we're not incentivized to do more work for anything more, we're going to regulate to our comfort. The second thing that contributes to this vicious cycle is that we're a medical system, and like all other medical systems in the country, we defer to experts at the bedside. And so we will accept the determination by an expert at the bedside. We don't centralize through policy very frequently, or through guidance or through orders, standards. We don't do a good job of that because our whole system has been designed to defer to the expert at the bedside. And so when you have a system that regulates to comfort, and you accept that the expert opinion of every expert at the bedside, this is what you get, a vicious cycle of liberal ER transfers. And this is a big deal. And this is a very, very complicated slide. But I'll just, and hopefully you can pause this and take a minute to look at this death spiral, which again is a mental model. But over time, as you transfer these patients out, because there's no tangible And again, and that's very, I'm trying to be very deliberate in the way I'm saying this, because there is tangible benefit, but because we don't perceive there to be any benefit to taking on more sicker, more acute, more sick patients, we transfer them out. And then with time, what happens? We don't feel comfortable anymore managing those types of patients. And then we start saying things like, well, our ICU isn't appropriate because we haven't managed those types of patients. We haven't managed the equipment that's needed for those types of patients. And you get into this vicious cycle, which is really, you can see over on the left there in that yellow. You start to transfer more and more patients. You become less comfortable having ICU patients. And then you even reduce the size of your specialty care services. So it's a death spiral. And this is allowed to exist because of the differences between our system, which is socialized medicine, and I'm looking down at the bottom of this chart right now, versus a free market system. And I just like to spend a second or two going through this. As mentioned previously, because we're salaried, we're going to regulate to our comfort level. A free market, the capital system that surrounds us, regulates to the maximum profitable capacity. And that's why, and maybe I'll talk a little bit more about working on the civilian side, which I was able to do for 2 years as a cardiologist. They take on every single patient they can. And when you're on call for a inpatient cardiology service in a civilian hospital, there is no limit to what you take on. You admit everything that comes in that day, because your administrative personnel will later bill again those insurance companies for that revenue. And you need to if you want to make a ton of money and stay afloat. Anyway, there's a difference there. We're comfortable doing less. In the free market medicine, the system is uncomfortable doing less. Again, because it's their existence that's at stake. In other words, if you said, "Hey, no, I'm not going to accept these patients," how would you make money? You couldn't. Again, in going back over to socialized medicine, third bullet, the system is adverse to proximate risk and becomes less skilled. And by proximate risk, I mean those things that I just described: a patient going down, a patient getting sicker, et cetera. In free market medicine, if you go to the right there, the system is comfortable with risk. And because they become more and more skilled. And again, the doc that accepts everybody to his service and runs a very, very large, very, very sick service becomes more skilled over time as compared to the one that defers to network or refuses to accept sick patients in. And by the way, and this is just a theory, so I'm sure people could argue with what I'm saying. But having worked on the civilian side, it's all baked in. So yeah, you assume more risk, but you also have medical insurance, malpractice insurance, and they're comfortable with that risk because their malpractice insurance is there to help back them up. Okay, so in our socialized medicine system, we're apathetic to patient needs, and this is a little bit off topic here, so I won't spend too much time. But if you go to the very bottom bullet on this slide, our socialized medicine system is generally ignorant of existential risk. That means these small practices that we do every day to defer patients to the network or decide not to take them on put us at risk, threaten us on a larger scale than what we know. And these risks play themselves out over years. And again, this is the example would be a hospital that at one point was very good at, for example, doing surgeries, who had decided to assume less and less risk. Their ICU may be downgraded to a step down, for example, or maybe the ICU even goes away. And they stop doing those surgeries. And then just with time, the hospital's very relevancy comes into question. And again, to contrast that, in free market medicine, they have to take on everything they can, because if they don't, they're at existential risk. So this is the deeper theory why I believe that we're comfortable transferring patients out. So what to do about it? You'll remember on the last slide, I kind of diagrammed the problem as being a system that regulates to comfort and that accepts variance. And so our recommended solution is to regulate to the provider, army, and patient needs, and then to ensure that we're not allowing subject matter experts at the bedside, at all these many different bedsides, be the determiners of our fate. And how do we do that? That's by ensuring top-down standardization. And that's what this performance improvement project is going to talk about. And so I'll spend a little bit of time here. This is part of a larger performance improvement campaign, I'll say, looking at value-based, a system of value-based medicine. But the third bullet there on the left, we decided that we're not going to let the expert at the bedside determine our fate as a unified organization, that we're going to put some rules in place and watch how our system and our leaders respond to those rules, and make sure that that we get after what our patients need, what our provider needs, and what the Army needs. And I'll discuss that in the upcoming slides. So this was our methodology. Let me move my face here. I can't seem to move it, but so very, very quickly and easily, we stood up a emergency transfer policy. This happened in July of 2019. And as anybody in quality and safety knows, the fact that you make a policy is not the same as making a policy to which everybody's adherent. So we started by making the policy, and then we followed up that policy with weekly transfer rounds. And then we did iterative performance improvement to get those transfers down. Okay, so you'll see there's four sort of bubbles here. Number one, the creation of the policy. Number two, following up every single patient that was transferred out of our hospital to see whether it was appropriate, whether there was a capability mismatch, and then to use that information to educate our providers so that they could get better and better and learn more and more and become more and more of a learning organization collectively to get better and better at taking care of sicker patients. So that was the follow-up. We met with all of our providers on a weekly basis and had these academic, just culture type of rounds. Our goal wasn't to blame or browbeat anybody. It was to improve our system. And then we got after it with performance improvement. So I'll show you how we did that one by one. First of all, the ED transfer policy. You can see that was published in the same month there. We said if you go down to see a patient, no, let me backtrack there. The first rule there was all projected transfers or meds should require some sort of consultation. So in this one, what I was trying to get at is the emergency department should never transfer a patient without including our providers here, even with clear cases. So I'll give you an example. We have an MOD, which it could be an internist or a family medicine doc. Prior to this policy being in place, if the ED saw a patient that was just an extremis or critically ill, or for example, was in the midst of a heart attack, they wouldn't even consult our MOD because, to be quite frankly, there wasn't a lot we could do for them. And I don't have any problem with an expedited transfer for a patient that needs it. However, that deprives our family medicine residents, our internal medicine docs, our specialty providers of an experience of taking care of a very sick person. And so while I didn't want it to get in the way of the transfer, I said, even if it's clear that that person needs to be transferred, I want our consultants down there to help you manage at the bedside these sick patients as they go out the door. So I didn't want the ED depriving our specialty services of reps, for example, with sick patients. And by the way, it's not going to hurt the patient to have another expert at the bedside helping the ED doc. Now, the caveat was that it shouldn't get in the way of the expedited transfer, but that was the policy. All transfers require consultation with either BAMC another consultant, or the virtual medicine. Um, and that was to enlist specialties. There's expert knowledge that we didn't have there. You can see there, point number 3, knowledge gaps are not capability gaps. And I'm not going to talk about this again, but and you can read the bullet that's right there. But I just have a problem with, for example, as an internist, transferring a patient with ITP, which is a common hematologic issue, one that can be run by an inpatient team with consultation from hematology. I had a problem with that not being done in a hospital and simply being transferred to a civilian team. And again, why is it important? It's important that our internists, our family medicine teammates, are fully have the full experience of taking care of all of these types of medical issues. And if we can do it with our consultants from BAMC and elsewhere, that's what we should be doing. And by the way, it's good for the patients. The patients want to be taken care of us. They don't want to get into an ambulance. They don't want to and go somewhere else. The care that we provide here, most of the time, is free of charge, where it's not at some of the civilian places because of the insurance plan. And they really truthfully want to be taken care of by their own docs. So it's not good for the system. It's not good for our patients. And then you can see there 4, 5, and 6. One thing that we also did was closed our ICU, and what that means is we developed we had intensivists, but those intensivists were consultants to either the internal medicine team or the family medicine team. What I'd preferred that we did was admit those patients to the ICU team and then have the MOD co-manage those patients until they were ready to come out of the ICU, but not have their care run by the MODs, just because, quite frankly, we weren't, we hadn't gotten our skill sets up yet, and we weren't comfortable doing it. And so the default frequently was to transfer the patients. Okay. So this was how we tracked it. We have basically 6 neighboring hospitals that we use. And we have fabulous nurse case managers. And by the way, CREAMC just has a fabulous staff all the way through. But and we have access to every single one of the electronic health records that are out there. And so every single patient that was transferred, we followed them up. We looked at their narrative summary and what happened in those hospitals, and then we met together. And here you can see all of the people, and we meet together on a week-to-week basis, and we see, was that transfer appropriate? Or was it preemptive? Preemptive transfer being one where the patients haven't declared themselves, but because we're risk averse, we want them to declare themselves elsewhere. And I just know this is a problem because the vast majority of these preemptive transfers don't go on to require higher level of care. Much of the time they declare themselves as not having a significant issue in any event. So these were the questions, and it's really it's a go, no go. Was the capability used at these other facilities that we couldn't have provided here? And then we had robust discussion. And again, this was grand rounds type, or just like morning rounds, you'd have academic with the goal not to hurt anybody's feelings or make them feel inadequate, but to learn. And that's how we got after it. And every single week, and we continue to have these transfer rounds every week. And this is what we found. You know, it's not just merely a matter of behaviors. I talked about that vicious cycle of, you know, regulating the comfort and variance being permitted by delegation to experts at the bedside. These were some real issues. We had communication problems. In some events, we have residents that weren't talking to their attendings, or in some case, they were briefing them the transfer as a done deal. It wasn't the detailed sort of presentation that I've come to I've grown up with being working at academic medical centers. And you can just see that there's quite a number of things here. These are cultural things, and I'll just give you a moment to go through those. Here's what we discovered, though. There was some low-hanging fruit that we could gin up to make ourselves a better hospital. We just weren't using it. And I'll just give you an example. And I keep on going back to cardiology, and I apologize, but that's where I've grown up. But also, you recall that it was the #1 reason for transfers. A lot of time, a patient wouldn't declare themselves as having a heart attack, but they would be concerned for it. They say, "Oh, we're going to transfer to Seton because they have a cardiac cath lab there." Um, and their reason for their justification for transfer was so we can see the inside of their coronary arteries and see whether there's a lesion there that would need to be fixed. Well, we have a CT scanner. We have two of them that have the ability to do just that, to do CT angiography. And it took about a 2 month or 3 month period to get all of our radiologists trained up on that. And that, by the way, resulted in quite a bit of improvement there. But what I'm getting at is by meeting weekly, it wasn't just a session to educate our providers. It allowed us in the command suite to see some very real capability gaps that we could really get after quite quickly. And so, setting up our CT scanners to be able to look at coronary arteries is one thing. We worked iteratively with our consultants at BAMC and elsewhere to help them understand how they could help us. We developed MOUs, and I think I'll show that in a little bit later. But we did all of these things, and just because we continuously learned about how we could be a better hospital. And it all has to do with the ER environment and the environment of our consultants working back to their attendings and specialists elsewhere. It was improving that network that we were after. So here are the things that we did. And this, again, is just that point that I was making, that the transfer rounds, the spreadsheet facilitated the transfer rounds, which facilitated visibility of a number of issues. And here are some of them that we all got after. And by doing that, we improved our process. So offsite communication with CRIDIAMC, and we've since created an MOU there. I asked our new family medicine residency director to reform our communication techniques between MODs, family medicine residents, attendings, and the ICU staff. We closed the ICU, and again, what does that mean? It means that there's a designated intensivist team to manage those patients that need it. The MOD team would admit the patient. They would then go to the ICU, be managed by that team, but the MOD team, the hospitalist team, would follow those patients until they were ready to come out of the ICU, and then they would continue their course. We educated and or acquired capabilities, and I mentioned the level 2 CTA certification for coronary angiography, but we also acquired a CRRT capability, which enables us to do continuous renal replacement therapy, which can help with short-term dialysis type things. And so our performance improvement project allowed us to look at many, many different aspects of our care system here. And what did we find? So here are our results. You can see there that was the famous month of July 2019. We had 108 patients transferred. And ever since then, we've had a progressive decline in transfers out. And currently, we're in November right now. Very, very few, very rare for us to have a transfer out. Again, ask the team to look at the capabilities that the patient was transferred out for, the justification, and how many actually used the capability that we didn't have at CRIDIAMC. I mentioned earlier, in that July, this was before we kicked in the performance improvement project, 84 out of 108, or 77%, ended up needing a capability that we could actually provide at CRIDIAMC. In June of 2020, 1 year later, only 4 patients did we transfer. In retrospect, when we looked at their hospital course, did we have all the capabilities that we needed for them? This is our hospital census, and remember we started this in July, and so what I have there is the first row there is July 2018 through 2019. Then you can see this is the hospital census for Med-Surg Peds ward. So you can see that first row, those are the average census per month. And then the next row is after we started the performance improvement project in July, what was our improvement? So we're increasing the census of our ward. And then you can see in COVID-19, it went down. That was intentional for a lot of reasons that I won't go into. And then you can see for our ICU, remember we had a 6-bed ICU previous to the the intervention, what our population was there, our average monthly census, and then 12 months of PI, or the next 12 months of PI, what our census was there. And I wish we had more data because, and I do have more data, I just didn't get it in time. We just continue to improve our census in both of these wards and getting better and better. Now, you might ask, what did the staff think about all this? And this was a staff survey that we provided. And you can see there, these were Likert or Likert questions, and we had broad support for keeping more patients within the hospital. Again, this was the performance improvement practice. The policy, in a way, was the easy thing. And the point I guess I want to make is you can't just create a policy and expect it to work. You really need this oversight, follow-up, and transfer rounds to really make it happen. Otherwise, you know, it's kind of like worth the price of the piece of paper that it's written on. And I think that concludes my my brief. So one thing that's happened is since we've started this process, we've had a couple of code blues. I'd never seen a code blue. For the first couple of months, there was rarely a code blue, and now every once in a while we have a code blue. We're doing things that I think are pretty impressive. We're treating a fair amount of PE patients with thrombolytics before we would transfer many of those out. We're taking care of cancer patients. We're taking care of patients with congestive heart failure, which used to be a knee-jerk transfer out. We're doing it all with consultation from BAMC. And by the way, there are great teammates up there too. And they're encouraging us to keep patients that even I, who consider myself fairly risk, I guess the opposite of risk averse, they're having us keep even sicker patients than what I think is appropriate, and we're having great outcomes. But when we have a code blue, I ask the team, you know, how do you feel about it? And everybody typically has a very, very positive response. We did all we could for that patient. The patient was at the end of their life, and we were able to get after them and give them the best care that was available to them. And so I think there's significant, multiple benefits from this process. I highly encourage it. I'm happy to answer any questions, but I begin by asking the question. Just ask the question, gather data, and see how many patients are being transferred out of your emergency rooms that if you could gather the data, could have been treated in your facility. I think it'll be surprising, and hopefully you can look at a performance improvement project like ours and help us as the MHS get after this. Okay, thanks everybody. This is Colonel Malish.